I think just about everybody's connected. That's great. So yes, I want to welcome you all to the Essential Substance Abuse Skills training for today. The session is titled Treatment Knowledge. My name is Steve Steiny. I am one of the managers here at the National American Indian Alaska Native Addiction Technology Transfer Center, located at the University of Iowa. I'm broadcasting to you live from the University of Iowa campus at the College of Public Health. Thrilled to have you all with us today. I've got a few introductory slides that I'll go over, and then we'll transition, and I'll pull up the presentation slides, and we'll begin. So sit back and enjoy. If you have questions, you can either use the hand raise feature, unmute and ask a question, or use the chat box. And I think Dr. Garcia and I are going to try and circle back to these at the end of today's lecture so that we can have a dialogue. But if you really have a pressing question or something that needs to be addressed right away, we can take questions as we go. Okay. Again, I want to welcome you all to the ESAS broadcast today, March 2nd, 2022. This event, as most of you know, is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. And as I mentioned, we're located at the University of Iowa here at the College of Public Health. We are made up of a large national HTC network, including 10 regional centers, National Hispanic and Latino ATTC, and an ATTC network coordinating office at the University of Missouri. Let's see if I can get my slides to move for me here. There we go. I've got all of your pictures now hovering right in the middle of my screen. So it's great to see you, but sometimes you guys get in the way. This project is supported and funded by SAMHSA. The content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian Alaska Native Addiction Technology Transfer Center. Following today's event, we will send out a follow-up email, which will include links and PDF copies of today's presentation. There'll also be a link to the recording of this event. And if applicable, which it is, there will be information about how to request CEUs for this webinar. We will offer 1.5 CEUs, NADAC approved CEUs for attending today's event. Lastly, there will be a link to a short survey. This survey is very important to our center and to our funders. It ensures that we're able to continue to provide events such as this. Your participation, of course, is voluntary in this survey, but we would really appreciate hearing from you, taking a few minutes to complete this. You can skip any questions you would like, and all your responses are kept confidential and cannot be linked to you in any way. If you have any questions about this survey, please reach out to me here at the center. You can certainly reach out to any of our Native Center for Behavioral Health staff or Dr. Garcia, and we're happy to answer any questions you may have. I know we're gathered here virtually today, but we want to take a few moments to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Mr. Sean Bear. Thank you. Without further ado, I want to introduce our speaker today, my colleague and my friend, Dr. Avis Garcia. She is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. I know she's currently and recently relocated and is in the great state of Montana, and we're happy to have her here with us today. Avis is a licensed professional counselor and an addictions therapist. She also holds her doctorate in counselor education and supervision with a specialty in substance use disorder treatment and work with Native Americans. She has got many, many years. I'll let her tell you a little bit more about some of her work experiences, but she's worked with a variety of different populations and all centered around behavioral health and substance use disorders, and as well as some other offshoots from those disciplines. So really happy to have her here. I've known Avis for about 2.5 years now, and really have gotten to enjoy getting to know her. So happy to have you here, Avis. And remember, you're all currently muted. Please use the chat box feature if you have any questions, and we'll try and circle back to those at the end of today's lecture. So really happy to have you here. I'm going to turn the floor over to Avis so she can talk a little bit more about herself and what brings her here. And while we're doing that, I'm going to change the slides around. So Avis, you have the floor.
Okay. Good morning or good afternoon, whatever time zone you're joining us from. Currently, I am the clinical services director for the Crow Tribe substance abuse outpatient treatment programming. We recently changed the name of the agency to Absalikai Healing. And part of that was to, the name change itself was to try to address the stigma. And a lot of the work that I'm doing at the recovery program is also now incorporating some prevention work. So I want to make our treatment program not a place for people that go just for treatment, but to have some community involvement, especially when it comes to like the cultural activities we're doing at the program I direct now. Right now I'm broadcasting to you guys from Bozeman, Montana. I am here for Indian Health Leaders meeting, and it's really a big change for me coming from the Wind River Reservation, where I am a Arapaho on my mother's side and Shoshone on my dad's side. So I'm affiliated with, with both the two main tribes there. Here in Montana, there are like 8 tribes. So when we have these meetings, it's really interesting for me to see all these people that are doing all these great things for like these 8 different tribes here in Montana, and know what's going on in the state here. I've been with the Addiction Technology Transfer Center since 2019. I have my doctorate in counseling and supervision from the University of Wyoming. I have been in the mental health and substance abuse field for 20 years now. So kind of dates me there. I've been in all phases of treatment. I've done a variety of different types of counseling. And I tell people that addiction work is job stability, and it's one of our biggest needs in Indian country. So I'm always recruiting, I'm always encouraging, I'm always supporting people to get involved in the work that needs to be done in our tribal communities. So I'm glad you guys took the time to join us today so we can get on to the essential skills. And this is my second go around with this whole program, but I enjoy doing it because it just further ingrains this information and knowledge into my brain. So I like being able to lead these webinars. We can go on ahead and get started, Steve.
Okay, Avis. Yep, I'm making sure everybody can see the full screen, and Violetta said she can see that full screen, so I appreciate that feedback. I'll be advancing Avis's slides today, so Avis, you can just give me the nod when you're ready.
Okay.
And let's go ahead and move towards the training objective.
We are ready.
Okay.
Okay. Sorry, I'm working off of my slides. The training objectives. Today, we'll be focused on gaining better understanding of evidence-based practices, best practices, and promising practices. So I'll explain the differences of those. Gain a better understanding of the importance of the treatment alliance. So that is us working with our clients and forming an alliance with them. Becoming familiar with commonly used evidence-based and best practice approaches. Better understanding of co-occurring disorders and integrated care, as well as explore medication-assisted treatment using buprenorphine. Can go to the next. Evidence-based and best practices. Evidence-based practices are methods or techniques that have documented outcomes, ability to be replicated, and have been recognized in scientific journals. SAMHSA has a lot of the TAPs, and if you log on to their website, all of these are free. They used to mail them in books, but now you can just download a PDF on evidence-based practices in substance abuse work. And evidence-based to me is really limited in Indian country. There are very few programs that I'm aware of that are, specifically proven to be effective with Native Americans. So there's a lot of research, a lot of statistics, a lot of numbers. And I know as an Indigenous person that we are more involved in qualitative type of research that includes our story, our language, our beliefs, and that is much different. The best practices are methods and techniques that have consistently shown results superior to those achieved by other means. In addition, a best practice will evolve as empirical research advances. And I like to look at best practices as an Indigenous person we know what works in our tribal communities. There are over 500 and I think 67 federally recognized tribes now, but we all have our different languages, our different beliefs, but we know what helps our people. So to me, anything, our powwows, our crafts, our language, a lot of that stuff, our culture is our biggest protective factor and a known best practice in our communities. Promising practices is generally described as having a body of evidence, either evaluation studies or expert consensus to support efficacy is likely to raise to the next level when scientific studies can be conducted and/or has been endorsed by one or more groups whose opinions matter, producing specific desired outcomes. So those are the differences between all of those. We can go to the next slide. Characteristics of addiction. Looking at the ASAM, the American Society of Addiction Medicine, the 3rd edition describes the characteristics of addiction as an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and as a dysfunctional emotional response. You can go to the next slide. Okay, our goals for treating substance use and co-occurring disorders. The first one is to properly assess the patient using multidimensional tools. The next one would be to provide integrated, coordinated, longitudinal care using evidence-based approaches. So this is combining several types of programs into that person's care and planning on doing it in a long-term base using those evidence-based approaches. The next one would be to provide an optimum opportunity for healthy behavior change through the Therapeutic Alliance. So that is the counselor's relationship with the patient. The next one would be to improve the patient's overall health and wellness. So, we often want to encourage our clients to go get a physical, go get themselves, all checked out to take care of themselves and practice some wellness. Maybe they don't have a healthy schedule or they don't eat very healthy. So just looking at the different things you can use. Indian Health Services provides a lot of those programs too. It's just being resourceful in your community and measures outcomes. So we want to be tracking your outcomes for quality assurance and to provide informed consent. Individual, family, and community, those recovery-oriented systems of care. Go to the next slide. What does this all mean? We have a responsibility to improve service, delivery, and monitor patient outcomes. The field of addictions treatment is evolving and will require a broader understanding of the term treatment. We have a responsibility to stay informed about evidence-based practices, best practices, and promising practices. So I know trauma-informed care has been a big one. A lot of suicide intervention has been a big one. So making sure your staff are being trained in the latest best practices and evidence-based practices that are out. Those in leadership positions have a responsibility to prepare and mentor the next generation of addiction professionals. So we gotta always be recruiting. The therapeutic relationship. The more we involve our patient in the decisions about their treatment process, the more meaning and purpose they will associate with their treatment experience. And that is our quote by Mr. Steve.
I don't know who that guy is, but he might, sounds like he knows what he's talking about. I don't know.
Yes. This clearly explains what the person-centered treatment process is. Working with CARF, there's a big emphasis on person-centered care. So I like this definition because the person-centered care is making that person feel like they're in charge and they make the decisions on what their course of treatment is going to look like. Okay, so what does this statement evoke in your own thoughts in working with mental health and substance use disorder patients? Just a question. I can't see if you're getting any response back, Steve, because I'm working off of my slides.
You were asking a question?
Yes. The question I asked was this quote that we just looked at.
Yes.
What does this statement evoke in your own thoughts about working with mental health and substance use disordered patients? Nobody? Okay. Patients are much more likely to remember how they felt when they worked with you rather than what you said or did with them during a session. So building that therapeutic alliance with the patient is very important. This is where you allow yourself to see the patient as the expert on their own lives. So getting them to think about times they were successful in maybe using refusal skills or taking care of their mental health issues and being able to build their self-esteem.
I think about utilizing some MI techniques, and the example I thought of was, for example, if I do a collaborative progress note with the patient, I'm asking them, does this sound right, or does this sound like what we worked on today? I don't know if anyone's doing collaborative progress notes, but with certain patients, it really empowers them.
I do. I write it right with them. And I tell them I take the last 10 minutes of the session to write that note, and I, read word for word, and, I'll even let them look at the screen and if they want me to change anything. So it's having them involved in that. Good point. I'm glad you brought that up.
Violetta says, on one hand, I think everyone wants to be able to be a participant in their own care. On the other hand, I witness clients in their addiction behavior despondent about their care. For example, their wife or children may speak more for them, and that's the arrangement that works. And then she goes on to say, that's the arrangement that works could definitely be debated. Many times that arrangement works until it doesn't. Good point.
I like that she brings that up. It's also, it's good to have family involved, but then it's also good to look at those family dynamics there. And then I also deal with, I'm working in Crow country, and I've had it pointed out to me a few times that some of the clients that do come in are very traditional, and that they're not going to feel comfortable sharing like anything personal in front of a group of people. So we've been doing more one-on-ones to work with those people until they're ready to join a group and participate. It's just the cultural way for some people. Good. I like that she brought that up. We go to the next slide. The Therapeutic Alliance, or the Therapeutic Relationship, also known as the Therapeutic Alliance, is important to develop rapport. So what does rapport mean? Okay, the rapport is being able to have that communication with your clients, that they're open to talking with you and working with you, having common or shared goals, and building safety and trust. Looking at our ethical responsibilities in that, having boundaries, and looking at the power distribution and how that person views you as the helping professional.
Allie says comfort and trust in response to your question.
Okay. There's no right or wrong answer. That's a good one. Thank you. Comfort and trust. I have to agree with that. And I always tell my staff that sometimes I have peer specialists that work for me, and then I have some administrative staff, and sometimes they tend to gravitate towards other people in your agency. And sometimes they're like, my staff will be like, but I'm not a counselor. And I'm like, they just want to talk to you. So obviously there's something about you that they're drawn to. So I was just in a meeting where I'm cross-training a lot of my staff so that they could be more participatory in the treatment programming that we have. The therapeutic relationship, and again, the ethical responsibilities of doing no harm. Okay, we can go to the next slide. The therapeutic relationship function. It is for positive reinforcement, encouragement, instilling hope, and building self-efficacy, and working with people in the recovery field. I see a lot of people that really struggle with self-esteem. And so I really look at strength building in the work that we do. So I just thought I'd put that out there. Providing the patient with support and accurate and genuine empathy. In partnership with the patient, develop goals that are realistic, attainable, and adaptable, and model adaptive interpersonal functioning. So when we're doing our work, we're also modeling social skills for them. Therapeutic relationship in patient development. You want the patient to feel heard, understood, accepted, respected, and empowered. Feels that the therapist is concerned. They should feel the therapist is working with them. Feel the therapist is realistically optimistic, and feels and recognizes positive change is possible and are occurring. Looking at the ASAM under assessment, the ASAM criteria is clinically driven, not program driven. Criteria don't involve a prescribed length of stay. It's just based on the patient's status where they are, and to promote a flexible continuum of care. Involve an interdisciplinary approach to care. Include the informed consent, is outcomes driven, and to clarify medical necessity. So some of the patients have enter into treatment with medical problems, and sometimes that's why they're referred. So we always have to look at the medical needs as well. Some of the dimensions of ASAM, this is the patient placement criteria. There are 6 categories under the ASAM, with 1 being acute intoxication and withdrawal potential. 2 is the biomedical conditions and complications. 3 is emotional, behavioral, and cognitive conditions and complications. 4 is the readiness to change. Where are they? 5, relapse, continued use, or continued problem potential. And 6 is the recovery living environment. And each dimension can be rated as mild, moderate, or severe. The ASAM is also commonly rated in a 0 to 4 scale, with 0 being stable or minimal concern or risk, and 4 being seen as high risk and unstable and needing significant support or response.
Avis, I want to make sure we're synchronized on our slides. Which slide are you on?
I'm on 19.
Okay, yeah, I'm behind. So
Okay.
there's a continuum of care, of treatment.
I am sorry. I just kept going.
No, that's okay. I just want to make sure everyone is with us. So
Okay. I'm sorry, guys.
No,
Okay,
that's
keep
fine.
going, keep going.
Yeah, there we go.
Okay, here we are. The whole person/patient-centered care. Establishing the Therapeutic Alliance begins with the patient's initial contact with the helping professional or organization. Proper treatment requires proper assessment using the ASAM, and it is a commonly used multi-dimensional assessment tool. So when we go to the next slides, you know what? Go to your next slides. Yours are different than mine.
Aha.
No, okay. Okay.
Well, that makes more sense.
Okay. Next, okay. The multidisciplinary team approach using community support systems. Recovery-oriented systems of care. So all of the programs that can provide services to this identified patient. So we may have vocational rehabilitation, we may have the court system, we may have the family services system involved. So looking what all programs are there to support that person. Selecting a particular theoretical approach that is most likely to result in the patient's improved health. Okay. On to the next slide. Counseling theories and practice. Okay. My slides. Back up one, Steve. Okay. Yeah, mine are not lined up with yours. I am on slide 22 that lists the evidence-based practices. What slide are you on? Steve?
You're on mute, Steve.
Yes, I am on slide 20. This is whole person patient-centered care.
Okay, go to 22.
There's
Evidence-based.
a slide about Carl Rogers.
Okay. My
There's the main-
slides.
There's the main principles of the person-centered approach. And
My-
then we go to counseling theories and practice.
Okay, go to the next slide. Yeah, mine aren't matching up with yours.
Yeah, I apologize, everyone.
That's
We'll
okay.
make sure you get a copy of the most recent slide deck so that you can reference these
Okay.
at your own, in your own time. Sorry about that.
Back up one. Okay. Do you have the evidence-based practices slide? That's the title. Next one.
Yep, it's the slide after this one.
Okay. Well, okay. I'm trying to get to where you're at. Sorry, guys. My slides aren't matching up with yours.
You may have an older version.
I am gonna go on ahead and jump out of mine and put yours back on so that I can follow along with
Oh,
you.
I think that's a great idea.
Okay. Sorry, guys.
You can just follow along with with this one, and that way you're able to.
We're in two different places with two
I
different
know
slide
we're
decks.
in two different dimensions here.
Okay. Theoretical based approaches. These are concrete methods for assessing and conceptualizing individual conditions. Assist in increasing motivation to effectively follow a path to successful recovery. There's no one approach appropriate for everyone. So this isn't what they say cookie cutter. Everybody does the same thing. And a theoretical tool bag to select the best tools for the job at hand. So I like to say it depends on each individual. Okay, go on ahead to the next one.
Mhm.
Here's the slide that I was on, the evidence-based practices. There are several evidence-based practices. There is the one called behavioral theory by Skinner. There is the cognitive behavioral therapy, really popular, evidence-based in substance abuse and mental health by Aaron Beck. There is the contingency management incentivizing. That is an evidence-based practice if you're able to provide that type of service. Screening, brief intervention, and referral to treatment, known as the SBIRT. There is rational emotive behavior theory by Albert Ellis. Motivational interviewing is really popular. And then the stages of change, trans theoretical model from D. Clemente. And now much more popular is the medication assisted therapy. There are a lot of MAT clinics opening up now as I'm listening to these people talk at this meeting here today. You go to the next slide. The behavioral theory, some constructs to consider: that our behavior is learned, therefore it can be unlearned or changed or modified. New behaviors can replace old ones. So some people, whatever interests they have that they've never pursued, it might help them to make a list of some of the things they've always wanted to do and maybe look at those. Focus on the observable, so how people act, react, and behave. Less interested in the cognitive and emotional states, believe that behavior represents learned habits. So that's the behavioral theory. Not one I use frequently. Next. Behavioral theory, the conditioning. Those of you who've had Psychology 101 or 1000, I think they call it now, the classical conditioning that refers to the association between a stimulus and an involuntary or automatic response. The craving can be conditioned by a response triggered by a stimuli the patient may or may not be conscious of. So this is looking at Pavlov with the dog, where they ring the bell and the dog automatically starts to think it's going to get some food. And then the operant conditioning refers to an association between a voluntary behavior and a consequence by Alfred Skinner. The nature of the consequence will impact whether the behavior occurs again, legal, health-related consequences, etc. Go to the next. Behavior therapy key concepts. We have Ivan Pavlov, B.F. Skinner, and Albert Bandura. Some key terminology would be the classical conditioning, the operant conditioning, and the social learning theory. Some classical conditioning, the elements of associated learning, just like I was saying, there's is like a really, I guess, a classic theory of how classical conditioning operates. So looking at the bottom here where we see the conditioning trial, we have the bell, we have the food, and then the dog salivating. So then the test trial was just to see the response without the food, and it creates that automatic response. It's just what they're anticipating, and that's from Pavlov. Next slide. This is just a page here on using incentives. And it just goes to show that incentives can have a positive effect on treatment. And I know we are in a situation where our budget, we have a budget, but it's certain things are restricted. So we were just discussing yesterday how we could like get gift cards or even simple things like hygiene products and some things like that for incentives for people that attend our treatment programming, because it has shown to be effective to those that are in recovery, especially with adolescents. We can go on to the next slide. The motivational incentives equals contingency management. So this is providing reinforcement for healthy behavior, promoting awareness of motivational incentives. PAMI is based on the positive research outcomes learned from NIDA clinical trials network study that was titled Motivational Incentives for Enhanced Drug Abuse Recovery. Like I said, this was proven to be an effective intervention. And then there's a link there for more information. We go to the next slide. Why would we use motivational incentives? Well, it's to help them stay in treatment and to abstain from use, using low-cost reinforcement such as prizes, vouchers, leaving group early, or getting to have a pass for a group. Maybe they earned it. Praise, and not as bribery, but for recognition. Some ideas or fish bowls with little things written on it, and candy bars, tickets for a prize. Maybe there's a prize you have for the month and they earn tickets in a drawing for that. Maybe giving them notebooks, pens, books, planners, whatever you could think of that are inexpensive trinkets that might be helpful. Next. Cognitive behavioral theory, CBT, combines behavior therapy that helps to weaken the connections between troublesome situations and your reactions to them, and cognitive therapy that teaches you how certain thinking patterns and feelings impact your behavior. So it's blending the two of those together. Simply put, CBT attempts to help patients recognize, avoid, and cope. Next. Relapse prevention using CBT is to help identify high-risk situations, learn some coping skills, enhance their self-efficacy. Relapse is reframed as a teachable moment, having them walk through the situation again and how they would have done things differently. Challenge positive alcohol expectancies and lifestyle balance. Next. Key CBT concepts. The founder is Aaron Beck. The focus is on here and now, and the client takes on the active role using the ABC model. Next, therapeutic techniques. There's behavioral rehearsal. There's homework, motivational interviewing, relaxation training, systematic desensitization, social skills training, and assertion training. Definition, REBT is rational emotive behavior therapy. This is a cognitive-oriented counseling approach that focuses on changing the attitudes, beliefs, and negative self-statements that drive and maintain problematic behavior. Created by Albert Ellis in 1955. Next slide. REBT in a nutshell, this is something that happens to the patient. The patient has an irrational belief about a situation. The patient has an emotional reaction to the belief. The therapist helps the patient recognize errors in thinking that led to the irrational belief and finding alternative ways of thinking about that event. An example is, I was only arrested for drunk driving because that cop has it out for me. So how would they change that? The ABC model of REBT is A is the activating event. This is the events that occur in life that leads to the reaction. B is the beliefs, how the person feels or thinks about the activating event. C, emotional and behavioral consequences, how the individual behaves based on the beliefs concerning an activating event. The stages of change model by Prochaska and Di Clemente. At the very beginning there, up in the top corner, left corner is the pre-contemplation. Next is the contemplation, preparation, action, maintenance, once they've established it as being able to maintain it, and then looking at relapse and recycle. So if they have a relapse, then we need to get them back into the stages of change. Here's another book that is a really good book, The Motivational Interviewing by William Miller and Stephen Rolnick. It says, if motivational interviewing is a way of being with people, then its underlying spirit lies in understanding and experiencing the human nature that gives rise to that way of being. How one thinks about and understands the interview process is vitally important in shaping the interview. So it's getting them motivated to be more aware of the problems that they're having in their life so that they can focus on changing behavior. Really good book. I highly recommend it. Next. Back up. Okay. Motivational interviewing. The fundamental approach involves collaboration, evocation and suggestion, and autonomy of the self-rule. 4 principles are expressing empathy, not sympathy, develop discrepancy, and roll with the resistance, and supporting self-efficacy. Next. In my continued, clinicians commonly think they already practice motivational interviewing, though that's often not the case. What makes motivational interviewing a unique communication approach is how its constructs are employed by the clinician. And motivational interviewing requires attention to timing, issues, specific strategies, application methods, and maximizing the effectiveness of these skills. So if you can get training, it's really helpful. You can go to the next slide. ESPERT is a screening process. It is a screening tool used to assess patients' risk of having a substance use disorder. Some medical professionals are trained to use this screening tool. The B is the brief intervention, consists of a 3 to 5 minute motivational discussion with the patient concerning the screening results. R is the referral to a specific resource for additional assessment. And our treatment service, just like I said, we are referred from different agencies. So like I said, most clinics use this ESPERT. And T is the treatment provider. The process should allow for a warm handoff from the referral source to a treatment provider. Other theories worth mentioning is the social cognitive theory, personal factors, environmental influences, and behavior continually interact. People learn from their own experiences and from observing the actions of others. Next is the health belief model that helps to explain why people do or do not use preventive services. Has to do with the perception of reward and risk. And the social ecological model considers multiple influences on behavior and states that behaviors both shape and are shaped by the social environment. Behavioral health care and substance use and mental health. This is the behavioral health of integrated care. So when we're looking at substance use disorders, we're looking at problem gambling, we're looking at primary care and mental health. And I recently got licensed here in Montana as a LCPC and an LAC. And in order to get my LAC, I had to take 30 hours of gambling training before they would give me my certification. And I was, kind of grumbling about it, but then I realized there's casinos all over Montana. Billings, Hardin is just a small town. There's probably 3 or 4 casinos there. So the casinos are everywhere. And so Montana takes the gambling thing pretty seriously when it comes to certifying the LACs. So it's been very helpful to my addiction work. Next slide. A patient's substance use is not the problem, but rather a sign or symptom of other underlying issues driving the substance use. Something to think about there. Co-occurring disorder. What does this mean? In medicine, comorbidity is either the presence of one or more disorders or diseases in addition to a primary disease or disorder, or the effect of such additional disorders or diseases. The term dual diagnosis is used to describe the comorbid condition of a person considered to be experiencing difficulties related to a mental illness and a substance abuse problem. Any other ideas? Again, a big topic of discussion in my meeting this morning because I am encountering some clients lately with some very serious mental health concerns. And that little statement we read a few slides back that talks about if the substance use can be part of, what's that underlying problem that they're using to, some people say self-medicate. Go to the next slide. What are co-occurring disorders? It's the presence of at least two disorders, one being the substance use disorder, the others being a DSM-5 mental health disorder such as major depression, bipolar disorder, schizophrenia, PTSD, and anxiety. So we see it all. I want to say 90% of the people that come into outpatient treatment have co-occurring disorder. Go to the next slide. Some characteristics of co-occurring disorders in general. They repeatedly cycle through treatment, emergency departments, detox, and jails. More likely to reoffend are to receive sanctions when, for example, not taking their medication, they're not in treatment, they're not experiencing any mental health symptoms, and they're using substances. My staff are always on call for the Indian Health Services whenever substance use is involved with a patient in the emergency room. And part of what I've been working on here in the last couple of months is trying to help those people that are coming to the emergency room, that are cycling through these departments of how do we get them the proper help that they need, even when they don't want it, to help get them stabilized. So it says the use of even small amounts of substances may trigger recurrence of the mental health symptoms. So getting them to see that the use is really not helping them to get a better grasp on their own mental health issues. And it's not an easy task. Next. General assessment approach for co-occurring disorders is 1, the ASAM dimensions can be used as a multi-dimensional assessment tool for co-occurring disorders. So there is that mental health section that you would look at those criteria there. 2 would be assess the significance of the substance use disorder, obtain a longitudinal history of mental health and substance use symptom onset, analyze whether mental health symptoms occur only in the context of substance use, such as being substance induced, or determine whether sustained abstinence leads to rapid and full remission of mental health symptoms. So it's a tricky, delicate situation there. So you need to have mental health services involved. The next slide. Characteristics of co-occurring disorders. There could be a more rapid progression from initial substance use to higher levels of severity. Poor adherence to medication. There is a decreased likelihood of treatment retention and completion. Greater rates of hospitalization. More frequent suicidal behavior. Difficulties in social functioning, and a shorter time in remission of symptoms. So there's all of that to take into consideration when helping someone struggling with a co-occurring disorder. Characteristics include difficulty comprehending or remembering important information, such as the verbal memory, doesn't recognize consequences of the behavior, exhibits poor judgment, is disorganized, has a very limited attention span, can't focus for very long, and responds better to patient-centered care approaches. Co-occurring conditions in adolescents, 90% with a lifetime co-occurring disorder had one mental health disorder prior to the onset of substance use. So it looks like this starts at a very young age of having depression or anxiety or trauma, and then finding substances shortly after. So the median onset of a mental health disorder is about the age of 11. The onset of substance use tends to fall between the ages of 16 and 21. So a very high correlation. Evidence-based practices continued, pharmacotherapy and medication-assisted therapy. Go to the next slide. Pharmacotherapy can be used with detoxification and withdrawal management, can help with cravings for alcohol, replacement, aversive and antagonist, and mixed agonist-antagonist. Next slide. Medication-assisted therapy is the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to treatment of substance use disorders. So this medicated assisted therapy has to involve medical professionals, such as a physician and or a registered nurse. Medications for alcohol use disorders, there's naltrexone, there's Vivitrol, which is injectable, an injectable form of naltrexone and is longer lasting. And there is disulfiram, also known as Antabuse, and acamprosate, also known as Campro. Next slide. Medications for opioid use disorders. We have methadone in an oral liquid, naltrexone orally. Again, the Vivitrol is injectable, an injectable form of naltrexone and longer lasting. Sublocade, an injectable form of buprenorphine. Suboxone and Zubsolv, which is buprenorphine and naloxone. And Probufene, which is buprenorphine, and then can be an implant. Opiate and opioid, what is the difference? Opiate is a term that refers to drugs or medications that are derived from the opium poppy, such as heroin, morphine, and codeine. Opioid is a more general term that includes opiates as well as the synthetic drugs or medications, such as buprenorphine, methadone, misperidine, which is also known as Demerol, fentanyl, that produce analgesia and other effects like morphine. Next slide. Did we skip a slide? The base, okay. Basic opioid facts description is the opium derived or synthetics which relieve pain, produce euphoria and morphine-like addiction, and relieve withdrawal from opioids. Medical uses are for pain management and cough suppression. Methods of use can be intravenously injected, smoked, snorted, or orally administered through pills. And then the withdrawal can be very prolonged and very unpleasant, but not life-threatening. Next, a brief history of opioid treatment. The Drug Abuse Treatment Act of 2000 and the approval of buprenorphine by the U.S. Food and Drug Administration in 2002 for the treatment of opioid addiction both allow for the expansion of traditional opioid treatment programs beyond the current structure to include treatment in office-based settings. With this expansion, more patients may be willing to access treatment, and the stigma associated with addiction may be reduced by broadening the definition and location of treatment. And opioid addiction continues to be a significant public health problem across the country. In 2007, approximately 12.5 million Americans ages 12 and older used prescription pain medications for non-medical purposes, according to the National Survey on Drug Abuse Health Administration by SAMHSA. By 2019, full-scale efforts to systematically decrease the access to prescribed opioids medications over the previous decade have created a continual surge in overdose deaths and the ongoing use of heroin and fentanyl acquired illicitly in order to manage the addiction to these opiate-based medications, thus creating the epidemic we see cycling through our healthcare substance use disorder treatment systems of care today. And gosh, this just makes me think about a couple days ago before I came to Bozeman, we were having a discussion because one tribal program contacted me and asked if I could, or if not me, someone in my agency can come provide a presentation for staff. And they were talking about opioid addiction, people that are taking prescription pain medications and possibly being dependent on them and not realizing that they are. And so I had mentioned to that person over the phone that in just the short time I've been in Crow for 8 months, that I don't see these people come in that often unless we catch them through UAs. I don't, but then I hear that it is rampant, and I know we had this problem, I mean, on our reservation too. So they are probably, in my experience, the hardest addictions to treat. We go to the next slide. The brief history of opioid treatment continued. In 1964, methadone is approved. 1974, the Narcotic Treatment Act limits methadone treatment to specifically licensed opioid treatment programs. So there's certain criteria had to be met. 1984, naltrexone is approved, but has continued to be rarely used, approved in 1994 for alcohol addiction. 2000, the Drug Addiction Treatment Act expands the clinical context of medication-assisted opioid treatment. 2002, tablet formulations of buprenorphine, Subutex, buprenorphine, and naloxone, known as Suboxone, were approved by the Food and Drug Administration. We've been dealing with this for over a couple of decades. Approval of buprenorphine and naloxone. USDA approved buprenorphine, marketed as Subutex for opioid addiction treatment in October of 2002. Product launched in the United States in 2003. Interim rule changes to federal regulations. 42 CFR Part 8, May 22nd, 2003, enabled OTPs, specialist clinics, to offer buprenorphine. 2016, the first ever FDA approved buprenorphine implant for opioid dependence, Probufene. 2017, FDA approves first once monthly buprenorphine injection, a medication-assisted treatment option for opioid use disorder, Sublocade. Next slide. Buprenorphine treatment, the myths and facts. Myth 1, patients are still addicted. The fact is, substance use is pathologic use of a substance and may or may not include physical dependence. Physical dependence on a medication for treatment of a medical problem does not mean the person is engaging in pathologic use. Buprenorphine is simply a substitute for heroin or other opioids. That's another myth. The fact is, it is a replacement medication and is not simply a substitute. Buprenorphine is legally prescribed medication, not illegally obtained. Buprenorphine is a medication taken sublingually under the tongue, a very safe route of administration. And buprenorphine allows the person to function normally. Next. Providing medication alone is sufficient treatment for opioid addiction. The fact is, buprenorphine is an important treatment option. However, the complete treatment package should include other elements as well: talk therapy, community support, etc. Combining pharmacotherapy with counseling and other ancillary services may increase the likelihood of success, and research does support that.
And there are also, I would note that there are indicators that some research also says that there's no difference in outcome when patients receive counseling in addition to their medication. So that's the confusing part, is you get contradictory reports about this, but I thought I'd mention that.
Okay, that's true. Patients are still getting high. Myth 4. Fact is, when taken sublingually, buprenorphine is slower acting and does not provide the same rush as heroin. Buprenorphine has a ceiling effect, resulting in lowered experience of the euphoria felt at higher doses. Advantages of using it in opioid addiction treatment: the patient can participate fully in treatment activities and other activities of daily living, easing their transition into the treatment environment. There is limited potential for overdose. Minimal subjective effects like sedation following a dose. Available for office use in an office setting, and there is a much lower level of physical dependence. Advantages: discourages IV use, can prevent overdose deaths, naloxone. Okay.
That might be it for the advantages.
Yep, that's it.
I thought maybe there were a couple more on there, but
Nope. We just had naloxone training at our office about a month ago, and I thought it was kind of fun, but it was interesting to see that several agencies are now, even the local police on the Crow Reservation have been trained in using that. So just a brief summary of what we covered today. We covered the evidence-based and best practices. We looked at the Therapeutic Relationship and Treatment Alliance. We discussed some of the best practices. We talked about co-occurring disorders, and we briefly touched on some pharmacological treatment options using medication.
I was going to add too that one of the things, going back to the use of the naloxone, is they're running into issues where because of the fentanyl overdose spike, sometimes having to use more, 2 or more doses to bring someone out of an overdose when fentanyl is involved. I don't know if other practitioners on the call have had this reported to them, but the biggest issue with fentanyl is that it just stops you from breathing, and that's the main cause of death. Is just you just stop breathing, your respiratory is arrested. So
I do know the overdose rates in Indian country have gone up significantly during this COVID crisis, and I've seen it on my own reservation, and it's sad that there are those. Fentanyl is out there.
yeah, there's a movement as well to provide and arm everyone with fentanyl field kit testing units, so that you can test to see whether your product, it's a harm reduction approach for the user to see if there's fentanyl in their their expected dose of opioids and prepare themselves accordingly. There's some controversy surrounding that, but I think the harm reduction approach has got some validity as well. We have some time. Avis, I want to thank you so much. And I do apologize to the audience for us having not having our PowerPoint synchronized. We'll make sure we get that corrected next time around. But I want to thank Avis for reviewing a lot of information in a short time. We have a little time. I see a couple questions coming in the chat that I thought we could put out to the audience, and feel free, please, to unmute yourself if you'd like to also comment. But let me read a couple of these and we can see if we can respond. Avis, Violetta's asking, what are your views as presenters on the use of psychedelic assisted therapy for treating addiction? And I think you're talking about perhaps microdosing or some approaches such as this. And I can comment on that, but I didn't know if Avis had some thoughts.
No.
I was just going to say, I know that this is being utilized and implemented in Europe. They don't have as stringent regulations to utilize such things as microdosing, using microdoses or very, very minute doses of lysergic acid to treat certain mental health conditions.
Really?
There's some research that supports this, and it really is not new, but it's sort of gotten a resurgence. I don't think that this is happening though in the US.
I would hope not.
But I know that it might be something that we see surface in the next 5 to 10 years. I'm not sure though. And I'm excluding ceremonial practices, the use of certain hallucinogens.
Oh yeah,
I'm not going to address those, but I don't know if that answers your question at all, Violetta, but it's definitely something that I've read a little bit about, but haven't really investigated too much beyond that. There's another question, and Avis, I think this would be a good one to maybe to talk with the group about a little bit, or if we want to hear from others. Robert says, what about support through NA or AA or Celebrate Recovery? Is this a component to consider or vital?
I would consider this to be a best practice or a promising practice. Having been in the field for 20 years, I've seen all different, different viewpoints of AA and NA, and those are primary. I think they are vital, but we can't make them mandatory. We can't force our clients to do something that they're not interested in. I've seen some people that they were all non-native. So mind you, when I say this, those that I used to work in a DUI court, and from what I saw, the people that got a sponsor and went to their AA or NA meetings regularly had the highest success in the program. And that's from my own observations. But then I also come from the Wind River Reservation, and I've attended trainings that involve the Latino or populations. And I've asked questions of people that work with that population in those areas, and they really kind of frowned upon those types of organizations because they felt that it just added more stigma for that population. And I've seen it. So like I say, I can't, at one time the state actually tried to mandate that if you were in an IOP program in Wyoming, that you attend 2 of those meetings every week. It did not work out very well, to where they actually had to strike that out of their state standards of treatment programming, because it did not go well everywhere. But like I said, I've seen some huge success with it. One native version of it that I do like is through the Wellbriety, the 12-step program through White Bison. Don Coyhis is the guy who facilitates those trainings. And I think I just got an email today from somewhere of they are going to do one of those trainings virtually online. So I'm like, it looks like something I might want to get my staff involved in.
Well, any other questions? We do have a few minutes. You can either unmic or post something. Again, I want to thank everyone for attending today, and certainly for Avis reviewing the PowerPoint. Once we got synchronized, it seemed to flow a little better. But I just do want to appreciate everybody being on today. We'll be reaching out to you via email post-event. If you didn't have a chance to complete the survey link that I posted, please do that at the time of your follow-up email. At that point, you can request CEUs for today's webinar, as well as a copy, a PDF copy of the slides. And we'll post this event, recorded event, on our Native Center for Behavioral Health YouTube archive, which is also available on our website. So I want to thank everyone again, and appreciate everyone's patronage and attendance today. So we'll broadcast again next month, always the first Wednesday of each month. Avis, do we know what's up next on our, I'm going to look at my schedule here and see.
No.
What do we have coming in? We have in April, our April broadcast will be basic counseling skills. Again, this is in the context of treating substance use disorders, behavioral health, and also mental health considerations. So yes, Brandy is asking, where can we access the slides? Those will be included in your post-event follow-up email. So you should have a copy of these and in a PDF format to use for future reference. Again, thank you so much, everybody. Until next time, stay safe, stay healthy, and stay connected. Take care, everybody.